Thank you. Good morning. My name is George Giakoumetis. I'm a medical physicist. I'm working at AHEPA, University Hospital, and I belong to the Medical Physics and Digital Innovation Laboratory, School of Medicine. Sorry. What we are going to see today. Excuse me. Okay, now we're ready. So, this is a typical workflow for a patient who is going to have a radiotherapy. So, first of all, there is the treatment decision, the imaging simulation, the CT, the treatment plan, the QA, the plan approval. If there is not okay, we have to do it again. After that, again QA, and after that radiotherapy delivery, and for the doctor follow up, so to see what's going on. So basically, what will I discuss today? The treatment decision, the imaging simulation, and then treatment planning. Treatment decision is the decision of the doctor. He will see the file, the medical history. He will perform a physical examination, the evaluation. He's going to see the CTs, the MRI, the PET, everything he has the patient. After that, he will decide radiotherapy is appropriate. Maybe not. We don't know. I'm not a doctor. I'm a medical physicist. Where I came is at treatment plan. Here is the decision if this is going to be external beam or internal. External beam is doing with a linear accelerator, internal with brachytherapy. Before we go to the treatment planning system and see how we are going to have the plans, how to create the plans, we have to make some decision for the CT simulation, the positioning, the immobilization systems, scan protocol, and marking the area reference marking. Maybe it can be tattoo, maybe you can mark with a pen, anything you can do. So basically, for positioning, here are the basics position that we can have for the patient. The supine position, the lateral position, prone position. We have to decide if the hand's going to be up or down, or the head comes first, or the feet. We decide where is the problem, where is the anatomical region that we're going to see, to treat. So depends. Also, the patient can stand, he can sit on the table. It depends on the condition of the patient. So while we are doing this, we're trying to do the reproducibility of the plan, the positioning. So we are going to use some immobilization systems. It gives precision, accuracy that we want to have, to be honest. But before we decide what kind of immobilization, we have to see the anatomical region. It's very, very important. So after that, we are going to decide we are going to use thermoplastic mask, knee headrest, mouthpiece. We can use wedges of foam so we can keep still the head or the leg, everything. Vacuum bag. It's not common technique here in Greece, but it can be used. The belly board, breastboard, shoulder traction tube. There are many, many systems. So here I want to show you some immobilization systems that we have here. As you can see, there is the breastboard in the center. Is there a laser pointer? No. Do you have a laser pointer? Oh.
No problem. No worries.
Okay, sorry. So here's the wing step. It is used commonly for breast, for lungs patients. This is about for the feet, for the knees, exactly. For the feet, we want to keep them everything still. It's very, very important for the reproducibility for the radiation. In cases of head, we have the small, as I can say, mask, thermoplastic mask. And for cases of head and neck cancers, we are using the long mask. The difference, here we have the shoulders inside, here we do not have. It's very important with that we can keep still the shoulders, so to calculate with more precision. Good, okay. For the scan protocol, what we are going to choose, it's very important. It's very different, the KV, the mass for head, for lung, for prostate cancer, all depends from the anatomical region. The pitch factor, the slice spacing is very important, the field of view. But what can I say? It's very important for us after that. It's for the planning, because we know we want more details. We are choosing the slice thickness to be 1.25 millimeter. It's very, very important. There are many protocols. Some CT simulation can do 1.25. I don't know. They can do 2.5, but they can reconstruct the image for 1.25 or smaller. This is important to do also the VMAT, the volumetric modulated arc therapy. Okay, we decide which protocol we are going to use. We are scanning the patient. We are seeing the topogram. After that, we are going to have the images. And okay, the doctor says, it's okay, I'm fine, I like it. It's all the region that I want to have inside. So after that, we are going to have to use the BBs. We are talking about BBs. What is BBs? Radio pack markers. It's very, very small metal, kind of, I don't know to be sure to say if it's iron, I don't know. But it helps to precisely align the position of the patient. After that, we can use tattoo, because we cannot all the time put the BBs scan again and again in radiotherapy with photons. Okay, sorry. So we are using tattoos, or maybe we can use a mark pen to mark the region. To be honest, a point. It's only a small point on the body of the patient. Sure, the laser helps. It's very important to have laser for the alignment, as probably you know. So, okay, the patient goes to the CT simulation. We are having the images, great. They are sending the examination, and here comes, after that, the treatment planning system that is going to have all the images, all the information that we need for delineation, for dosimetry. Basically, what we want to hit the target, to hit the PTV, the planning target volume or planning tumor volume, whatever you want. Sorry, the PTV, and to protect all the other organs, all the healthy tissues. So basically, we want to discuss about contouring. It's very, essential for us. Now, after that, the origin and the associated, what we are going to select on the plan, and the treatment technique. Here comes the physics, the physicist, and decide, no, you're going to use 3D conformal, or maybe you can use VMAT or IMRT. The decision depends on the anatomical region, and of course, the decision is under the discussion with the doctor. Basically, what we're going to see from a plan here, well, what I'm expecting when a doctor says it's ready, you can go do the dosimetry. I expect to see the GTV, the CTV, and the PTV, gross tumor volume. The CTV is the expansion of the CTV, as you can see. The PTV. Basically, there are guidelines from ICRU, as you can see. After that, depends on always from the anatomical region. I'm going to see organ at risk. If I'm going to irradiate a brain, I don't want to see something, prostate, for example. I don't care. It's very, very long. It's very distant. For the delineation, it's very useful for the doctor to use MRI and PET. Okay. It's very, very useful. They can define where is the problem. Here comes the physicists that have fused the images of the MRI and the PET. It's difficult because many times the images from the MRI or the PET, they have different table from the radiotherapy. So they're all changing of the coordinations. It can be fused very good, but it's a very good method if you want to be more precise to use a table like radiotherapy. I think Theagenio, the PET has also a board, a table similar to the linear accelerator. So, and the CD simulator. Okay, before I start to do the dosimetry, I have to define where is my 0 point, where all must be done. So here I have the BBs, as you can see. Here I have the coordinations. And I'm trying to, as possible I can, to set the reference point. This is the origin. This is the first one. After that, I'm going to find where is the center of the PTV. It's the best you can do if you want, but it's not the gold standard. You can choose to have the not in the center of the PTV. Always depends from the anatomical region, and I will show you some cases that we have here with this problem. Sorry. So the decision, the big decision for us, the decision for photon therapy and what we have. Okay. I will talk only for 3D conformal, IMRT, and VMAT. I cannot talk about tomotherapy, or I cannot talk for proton therapy. I'm not. I can't speak about it. So, what we are going to need for 3D conformal, we need to know what is wedge and what is fifth. And for IMRT and VMAT, we need to know what is segment. It's very it's essential to do the radiotherapy. From the first image to the second image, you can see the difference that we have a better protection of the ORs. As you see, here is the OR. Here it is protected, might kind of, but we have a great sparing of the organ at risk. IMRT and VMAT, the difference is that we have some static fields that are moving and rotating, but VMAT is rotating all the time and delivering the beam all the time. So, wedge is a beam modifying device used in external beam radiotherapy to adjust the dose distribution with a radiation field. Basically, we are using something material, something like that, a metal, so we can change the beam, how it will go to inside the body, to the patient. And we are trying to do it so we can give the best dose for the PTV. After that, we have the field in the field technique. Is used to improve dose uniformity by dividing the radiation field into smaller subfields. It's very useful if you are treating breast, you have a plan for breast radiotherapy. And after that, segments. It's not the right thing to say, but it's like something like that concept. It's small fifths. It's not, but if you want to understand, and I will show you some images. Okay, segments refer to smaller radiation fields created by a multi-leaf collimator. The result is to shape and modulate the radiation beam so we can have a more precision for the treatment. Some algorithms, there are many algorithms, but what I want to say here is Monte Carlo is the most accurate, but very, very slow. We need time to calculate the dosimetry, not me, the computer. A very good, sorry, Monte Carlo is used for VMAT and IMRT, but for anisotropic analytical algorithm, highly accurate, okay. It can be used for IMRT VMAT. I don't think so. It's in my experience, small experience. Okay, it's good, very good, but Monte Carlo is better. Collapse cone, as you can see. The problem here, we have to to think about the heterogeneous tissues. This is very important. How much time do I have? Okay. So I want to show you some plans for breast, head and neck, prostate, and brain. First plan. Okay, nice. When I started as a medical physicist, I was looking at this picture and I was saying, okay, what is red? What is yellow? I understand there is somewhere there is a breast. Okay, this is the result from the dosimetry. We need to know the actual doses. We need to know the prescribed dose, what we want to give to the breast. Depends from the doctor always. And this is a plan from 3D Conformal. It's not the gold standard, as I said, but if you want to try to start to use the 3D Conformal for breast therapy, you have always to think, how can I see the target smaller? How can I see that? I'm rotating the country, or I can rotate the collimator, or I can rotate the couch. I have two basic tangential fields. What this means, tangential fields? I want to protect the other breast, I want to protect the other lung, and I want to spare the lung here for this image. This is the lung, the left lung. It's the left breast case. I want to protect as much as possible the left lung and the heart. With 3D Conformal, it's not so easy to protect sometimes the heart or the lung. So you have to compromise. So you have to think, what can I do? What can I accept? If the scores are all right, I'm going to ask the doctor. He knows where is the problem. He knows if it is okay to understand. So there is always the eyeballing with the doctor. The basic tangential fields must be 6 MV photon energy. We can use it with wedges. As you see here, we have the two wedges. The angle varies. Depends on the machine, of the type of the wedge. You can use 10 degrees, 25 degrees, 15 degrees, whatever the machine has. I don't think that bigger number from 25 degrees is appropriate. 25 degrees is basically for large breast. After that, when we are going to have the dosimetry and the calculation for the two basic tangential fields, we can create the fifths, the field in the field technique. So we are going to use smaller and smaller fields. So to, as I always say, to fill the dose inside the breast. What we can use? 6 MV, 10, 12, 15, 16, 18, whatever the linear accelerator has, the type of the model you have. What we should check always, the constraints for the lung and for the heart. It's basically always the problem is the lung. But we are going to put the beams in that way. We are going to rotate the country in that way so we can protect the other breast. It's basic principle here. We do not want to irradiate another region for no reason. The same result we can have with the fifths, only with the fifths, without wedge. I just put these images from the same patient. As you can see here, here is the same patient exactly. The result similar. But what is the cost by using fifth? The cost by using fifths is you can use 2, 3, 4, 5, many fifths. You are going to use small fields and you are going to give a small amount of the dose of the monitor units. So always a medical physicist must think, can I use so many things, so many fields? Might not. I don't think so. Maybe yes. Always depends from the plan. Always depends from the case. Here, we are looking for the constraints of lungs, for lungs and heart. There are many papers, articles that are saying that we are going to have a good sparing by using wedge or fifths. In result, I always say, okay, I'll do both plans and I will see and evaluate the results. This is the basic, sorry, this is the basic field, the basic beam, the first beam, as you can see. What I want to show you here is the fifth. The difference here is the leaves from the multi-leaf collimator that we are closing and shaping the dose by building step by step. So what are the constraints about the lung? What are the doses? What are the minimum, the maximum? We are going to discuss this later, but as you can see here, we are trying to accept the PTV minimum must be 95%, and the maximum dose of the plan for the PTV, we want to be 107%. 105 with 107%. We are done with 3D conformer. The basic principle for 3D conformer are the same for every region. You are going to use the 4-field box technique or the 3-field box technique. Always you are trying to do the best conformality for the plan. It's not very easy. The first plan with the 3D conformer is a straightforward plan. You are putting the beams, you are trying and error, and you see the results. Here in the IMRT and after that the VMAT is the inverse planning. What does mean? Inverse planning, so we are telling to the system, try to protect this, try to irradiate this, and calculate me the beams, calculate me the time, calculate me the dose, and I'm just checking the results. It's difficult, but always the decision what I'm going to do depends on the physicist or the appropriate dosimetrist. For breast irradiation with IMRT technique, you can use 3, 4, 7, 10, as much as you want, but you always have to count in your mind that many beams, okay, we are going to have too much time, because it's not only the time of the radiation, but it's also the time where the gantry must move, aim, shoot. I will suggest, if you want to start with IMRT, you can use always the basic tangential fields of 6 MV, or you can use the 10 MV. Most of them, of the linear accelerators, they are using IMRT and breast IMRT and VMAT, sorry. They are using the 6 and 10 MV. What I want to show you here, the segments. This is a beam from an angle of 0. The gantry is at 0. Here is one segment that it was calculated from the system. From another angle, I have a different segment. It's kind of fifth, it's not, because all the time here is using different segments and calculate the result to be more conformal and sparing the tissue as much as you can. Here is a result for IMRT. It's not the best, but this is not the best image. But what I want to show you here is that there is a good protection of the lung. With 3D conformal and FIF, we have the 95% isodose closer to the lung than here. This is an axial, this is a sagittal. Okay, we are having a good sparing of the lung. Here, we have VMAT. What is VMAT? Volumetric modulated arc therapy. So I'm using arcs. I'm not using beams here. So this is an arc. What does it mean? The gantry will rotate all the time and see the different angles, the PTV, and irradiate every time the machine wants and calculated from the algorithm of Monte Carlo. Proposal. I don't know, double half arc. Some other centers might be using 3, 4 double half arcs, no half arcs, all a full arc. It's just a proposal. I cannot say that this is always the best. Okay, you can use 2 double tangential arcs. There are smaller arcs. They are starting from here and end here. And from the other side, the same. The problem here is that to have the best conformality, the best result with VMAT, you want always to give solutions to the Monte Carlo. What I'm meaning? More angles of the country. He calculates step by step, angle per angle, how the system can deliver the best beam delivery. Always essential planes the collimator. You can rotate the collimator in 90 degrees, 45 degrees, whatever you want. The energy that you can use is always 6 MV or 10 MV. I could suggest 6 MV, it's okay. And the constraint for lung and heart, here we are having a good spare of the lungs, the left lung and the heart. But the problem here, we must think about it, is if the arc stops here, does the system see the other lung? So it must be delineated also the other lung. So we can put it on the constraints of the system and say, do not irradiate the other lung. Here, as you can see, it's more uniformity here from the other 3D conformal and the MRT. I'm so sorry. Here comes the challenge for us, for the medical physicists, the head and neck cancers. The head and neck cancer and the brain cancers are always tricky, they are always difficult, they are always a challenge for us because there are so many organs. We don't know where to stand, where to put the angles, the beams. So the VMAT is a very good solution for us because we are saying irradiate the PTV and simultaneously I want to protect all the other organs. Also, simultaneously you can give different doses other regions. For example, here this is the high dose, this is the medium dose, and this is the low dose. This with 3D conformal, it's very difficult to be done, and we are doing with phases. Here is the deviated dose volume histogram. What you can see, so many lines, okay. But here is the PTV, the red one. So here is the curve of the PTV, the red one. I always want to see the score of the PTV. I cannot show you because, sorry. Ναι. Δεν πέφτει εδώ.
Τι?
Πέφτει πάνω εδώ και δεν μπορώ να δείξω.
Is that the same one?
Yes, great. Sorry. Technical issue. Classic for physicists. So we are looking here. Here starts the PTV curve to fall. And we are trying to see the score is 100%, 95%, 97%. We will discuss later. What we suggest? Double arc. 360 degrees means full arc. Collimator depends. You have a large one, you can use the 90 degrees, so you can have a maximum. Always depends from the linear accelerator, the type of the linear accelerator. If you have a small field, you can rotate the angle of the collimator. If you have a large, why not? So, what I want to show you here, the energy that we are going to use is 6 MV. There is no reason to use 10 MV for VMAT because the region is small. The other region, to be honest, the distances are small from the surface of the skin. Here are some of the constraints that I have asked to look some organs at risk, like larynx, parotid glands, submandibular glands, lips, mandible, the brainstem. It might be the brainstem, might be the spinal cord. So many. Here we have a prostate treatment plan. I want to show you here in this image that the blue one is the low dose bath, as we are saying. It's a 10% of the dose of the prescribed dose, a 5%. It's very useful to understand the region of the irradiation. This is the target. So, yeah, he's using the segments. He's trying to irradiate the PTV, the target, but with VMAT, we are going to see here, it's a full arc. So there are so many entrances of the beam. So the result is to irradiate so many other organs, but it's very low dose. With protons, we do not have that problem. It's only two beams, as I have seen. Better results with protons. But what we have for VMAT here and the prostate, good conformity. It's not very bad. What we are always thinking and seeing for the constraints, bladder, rectum, femoral heads, might be testis, penile bulb, and the bowel bag. In this case, there is no need for bowel bag, but we are looking for the rectum and the bladder. The rectum is kind of radio sensitive, so we must protect it more and more. The other problem that I want to show you here is that this patient has a small problem. What the problem is, there is air. The air, I can say that it's a big problem for us because we cannot irradiate the air. The beam, the dose travels here, and we are not sure that we are going to irradiate the PTV properly, and if there is going to be a reproducibility of the plan. Maybe the patient will be coming from 10 days later, and there is no bladder, smaller, and the rectum is very small. So we have to adapt it. Okay. Basically, I'm finishing. Don't worry. Here, the brain treatment plan. The same. What I want to say here. Double arc. Again, 6 MV. Here we have the collimator, always depends. Here we can think and we can rotate the couch. Depends where is the damage, where is the problem. Here we have a rotation of the patient, of the couch. So the radiation is like doing that in a sagittal mode. The constraints, lens, brain, optic chiasma, nerves, many. Dose volume histogram. I don't want to say the basic principle of the DVH, but what I want to say with the other images that we have already shown is what we are looking, the V95% must be at least larger than 95%. What does it mean? 95% of the PTV volume to receive 95% of the or more of the prescribed dose. So if you have a prescribed dose of 60 gray, I want all the PTV be covered from the 57 gray, for example. Nowadays, we are using T95%. To check the maximum dose, we are using the D2%. And to check the minimum dose, D98%. The maximum dose, we don't want too many hot spots. We are calling this hot spots. We don't want to be larger than 110% or 107%. The decision is always from the protocols and the doctor. And also we must checking always the D50% is the median dose. This is about the PTV coverage. For the organs at risk, I cannot tell the constraints for the organ at risk because every hospital, every department has his own constraints. They are following some guidelines, maybe the Quantec, maybe the RTOG. So what I want to say is we are checking the organs at risk. We are checking the score. We evaluate if it's okay to be delivered. And we can use different DVH with different plans. So for a comparison, it's very important. After that, okay, we did it on the computer. Great. We are playing. We are changing the beams. We are changing the dose. We are changing. The essential, the crucial point here is the QA. We must test it. So we have here a phantom. For example, this is the last one, don't worry. We have the phantom here. we execute the plan in a QA mode, quality assurance. We have the beam delivery, we have the measurements, we are comparison the results from the system of the TPS and the comparison from the execution of the linear accelerator. We are using some acceptance criteria, 3% with 3 millimeters. What does it mean? We accepting the results and we are considering that there is a problem. If there is a problem, don't measure it. 3% of the doses and the 3 millimeters out of the position. The score, the GPR, the gamma pass rate, must be larger than 95%. Depends on the department. Also, the criteria and this one. For stereotactic, they are using 1-1. Some other departments might be using 3% with 2 millimeters. I cannot tell. I cannot say what there is not something standard, but always consider that this is kind of global. That was.
Thank you so much for your interesting and informative presentation. Do we have any question for our speaker? No, maybe a comment from me and a quick question if you allowed me. So indeed, every step needs to be taken into consideration in order to succeed a very well treatment planning. But what about the overweight people? There's been some cases that during the city, some images, we cannot see some images because of their size, of their shape. So what about this? Are you using any artificial wedges?
For me, Marta and Martin, no. The problem with these people, kind of problem, it's not the radiation. The problem is that with the CT simulator.
Yes.
If the gantry of the CT is large enough, so we can have the full image of the patient, it's very essential. There are some techniques that is using that we are taking the half of the patient with one raw data, and we are taking the other half of the patient, and we are fused the two images, and we're having one result. The radiation is not such a problem. We are going to use 10 MV or 15 MV. We have this kind of, as you can say, ευκολία in Greek.
Yeah, there is the possibility to do that. Also, my question was about the city images because it has been observed that you are losing some kind of data. But you said that you're taking the half of the patient and then you combine.
Yeah, it's one. Another decision, if we have to irradiate the breast, the left breast, we are going to use the Dacendia fields, the Frodritico-Fombal. So basically, we can set up the patient and take only the images for the one breast, and the other one can be not full image. We can use also the algorithm, but if there is any solution that you cannot use the algorithm, why not?
Okay.
It's not the best. I agree. Always the technology helps. Always some other solution might be better than what we have, but we are trying, we are thinking, we are always seeing another solution.